I am Dr. Kilpatrick. Today, we will architect a triage algorithm for a complex clinical scenario: isolated severe hyperandrogenism in a postmenopausal woman with a history of total hysterectomy and bilateral salpingo-oophorectomy, but with normal DHEAS levels.
When a patient's primary source of testosterone is surgically removed, detecting a severe surge of that exact hormone presents an immediate clinical paradox. Consider a 60-year-old woman who presents with mild hirsutism and severely elevated testosterone. The critical context is her surgical history. Exactly 1 year prior, she underwent a total hysterectomy and bilateral oophorectomy. This split-screen chart illustrates the exact nature of the discrepancy. On the left, we see the expected post-oophorectomy profile. Bilateral removal of the ovaries should cause testosterone to drop significantly, while DHEAS remains stable. On the right is our patient's actual profile: a severe, isolated spike in testosterone, alongside completely normal levels of DHEAS and androstenedione. Those normal DHEAS and androstenedione levels narrow the search significantly. Adrenal pathology typically elevates multiple androgens concurrently. A normal DHEAS level suggests the adrenal glands are not the primary driver. Because the ovaries produce more testosterone than androstenedione, even after menopause, this specific biochemical signature points towards an ovarian source. Yet, the surgical record confirms the ovaries are gone. Generating this volume of testosterone in an oophorectomized patient is a physical impossibility unless we invoke outside environmental factors or hidden occult pathology. Standard heuristic models fail under these conditions. To locate the true androgenic driver, we have to completely reverse engineer the lab results, discarding assumptions and evaluating every potential source systematically. An isolated, severe testosterone elevation post-oophorectomy is never physiological. It is a diagnostic anomaly that demands aggressive, step-by-step deconstruction. Before initiating a search for rare tumors, the immediate first priority is to rule out exogenous androgen exposure. Statistically, external application is the single most common cause of isolated testosterone elevation. This requires screening for hidden environmental sources, compounded bioidentical hormone preparations, over-the-counter testosterone-boosting supplements, and even inadvertent transfer from a partner's topical testosterone gel via direct skin contact. Once external sources are definitively excluded, the second immediate priority is identifying laboratory assay interference. This animation demonstrates why standard testing fails here. On the left, an immunoassay attempts to measure testosterone, but lacks specificity in female patients. It frequently yields false elevations by cross-reacting with other similarly shaped molecules. On the right, liquid chromatography tandem mass spectrometry, or LC-MSMS, precisely isolates molecules based on their exact mass and charge. Confirming the severe testosterone elevation via high-quality LC-MSMS testing is a strict, non-negotiable prerequisite. You cannot order cross-sectional imaging based on an immunoassay result alone. Only after stripping away outside hormonal interference and laboratory noise can we assume the patient harbors true endogenous pathology. With the testosterone spike biochemically confirmed by mass spectrometry, structural localization must begin immediately. The Society for Endocrinology protocol requires concurrent imaging of both the adrenals and the pelvis. A physical clinical examination cannot reliably differentiate between a small adrenal mass and an occult pelvic source. Both zones must be visualized. This 3D model highlights the female retroperitoneum, specifically targeting the adrenal glands. An unenhanced CT scan of this region is the first-line standard for adrenal imaging. The unenhanced CT provides a 99%. The radiologist is looking for specific malignant features: a mass size exceeding 4 centimeters, an attenuation value greater than 10 Hounsfield units, or irregular heterogeneous margins. While the patient's normal DHEAS level makes an adrenocortical carcinoma less likely, Rare testosterone-predominant variants of these tumors do exist. The adrenal CT remains vital. Simultaneously, the structural search must move downward to the pelvis to hunt for ovarian remnant syndrome. Ovarian remnant syndrome occurs when residual hormone-producing ovarian tissue is left behind despite a documented bilateral oophorectomy. This risk increases significantly if the patient has a history of endometriosis or required a difficult surgical dissection. To evaluate the pelvic sidewalls for this residual tissue, a pelvic MRI is the absolute mandatory modality. Standard pelvic ultrasound is actively rejected for this phase of the workup. Ultrasound lacks the positive predictive value necessary to consistently detect microscopic remnants of ovarian tissue buried in scar tissue. Missing an occult tumor or a tiny remnant is a failure of imaging modality. Deploying the combination of an unenhanced adrenal CT and a pelvic MRI is strictly non-negotiable. We now reach a difficult clinical scenario. Both the adrenal CT and the pelvic MRI are perfectly clear, yet the severe testosterone elevation persists on repeat testing. At this point, the diagnostic approach must shift from structural localization to functional differentiation. The first step is measuring the gonadotropins, luteinizing hormone and follicle-stimulating hormone. Suppressed gonadotropins, specifically an FSH level at or below 35 IU per liter, point towards an autonomous androgen-secreting microtumor that the cross-sectional imaging simply missed. Conversely, finding premenopausal LH and FSH levels in a post-oophorectomy patient strongly suggests the presence of functional ovarian remnant syndrome. When gonadotropin levels are ambiguous and imaging remains negative, the diagnostic workup proceeds to the GnRH agonist suppression test. This 28-day timeline tracks the test's mechanics. We administer an agonist, like triptorelin, to heavily suppress the gonadal axis, and then measure the resulting drop in testosterone to see if the androgen source is gonadotropin dependent. The clinical threshold is precise. If the isolated testosterone levels suppressed by more than 50% at 28 days post-injection, it definitively confirms that a gonadotropin-dependent ovarian remnant is the source of the anomaly. Dynamic functional testing isolates the hormonal source when structural imaging fails to visualize microscopic secretors. This logic tree maps the diagnostic cascade. Exclude exogenous testosterone, confirm via LC-MSMS, order unenhanced adrenal CT and pelvic MRI, then dynamic testing if negative. The philosophy is sequential precision. Clear artifacts first, hunt anatomically second, test functionally third. However, specific clinical red flags dictate abandoning this stepwise algorithm in favor of immediate surgical or oncological escalation. Anatomically, the discovery of any adrenal mass greater than 4 centimeters or one demonstrating greater than 10 Hounsfield units requires an urgent specialist referral. Systemically, any physical evidence of Cushing syndrome, such as proximal weakness or violaceous striae, or the onset of rapid progressive viralization, demands immediate intervention. An isolated severe testosterone elevation in a post-oophorectomy patient is a biological anomaly. It cannot be monitored or dismissed as a laboratory error without proof. Strict adherence to this reverse-engineered algorithm is the definitive way to systematically rule out malignancy and safely navigate the paradox of post-oophorectomy hyperandrogenism.
Thank you for your attention. Please like and subscribe.